Hi, everyone. Just putting Instagram on. It's going to happen. It's going to happen. It's always a little bit delayed. Okay, here it is. Wonderful. All right, everyone. Wonderful to see you. This is Dr. Isabelle Amigues, your friendly rheumatologist from Onabridge MD. I have removed the glasses. I actually don't need them. It was just to hide this really infected eye. And here is just a shout out to Dr. Zimski, who is an ophthalmologist and a very good friend on the Denver area. She actually does some really cool things with, she puts a laser, like it's sort of an IPL laser. If you ever do it on your skin, you can actually do it there. I don't know how it, I mean, I guess I know how it works a little bit, but it was pretty magical. I will tell you that. Within a day, I was actually within, like just after, it was already draining, doing much better. So shout out, thank you, Lauren, thank you. Really changed my my day and my week, and feeling so much better. It's still a little bit red, but I had like three, and it's never happened to me. I freestyle all at once. So pretty impressive work that she's done. So shout out to Dr. Zimski. If you don't follow her already, do it. She's on Instagram as well. I think it's at Dr. Lauren Zimski, Zimski. So big shout out to her. And today we are talking about DMARDs. This is a question that came directly from our YouTube channel, where one of you asked that question and asked, what about sulfasalazine? What about Arava? And so after several questions like that, I thought, we keep talking about all of those drugs, but what are DMARDs, right? And so what does DMARD means, and in what concept, and where are we putting them together? I think the first thing that I want to share is the fact that it's a very hopeful thing. We in rheumatology have amazing treatments, and the first treatments we had in the past was the non-steroidal anti-inflammatory, right? So NSAID. And then we developed, or maybe like steroids was coming, like first came. But basically we had those two. Like patient who had a rheumatologic disorder 30 years ago had not much options. They had anti-inflammatory that were either non-steroidal or steroidal. So we're talking ibuprofen for non-steroidal. So ibuprofen, Aleve, really, it does help, there's no question, but it doesn't change the progression of your rheumatologic disease. And then the steroid, which actually some people, we know some people would call DMARD. I don't like to call them DMARD because they have so many complications associated with it. But really, when you think about it, it's only in the past 20, 30 years now that we've actually had something called DMARD, Disease-Modifying Antirheumatic Drugs. Disease-modifying, that means what? That means that we have proven with studies that by being on those drugs, you do not progress the same way that if you're not on those drugs. So you don't have as much erosion, you don't have as much deformities, and you actually have less pain and less swelling. Okay, but the most important thing is that you do not develop erosion. In the past, this is actually important. Nowadays, and you hear me say this all of the time, our goal is full remission or minimal disease activity. So, right, our goal is no more pain, no more swelling, no more morning stiffness. If you have rheumatoid arthritis or psoriatic arthritis, all of those, that's our goal. Our goal is you don't even realize that you have a rheumatologic disorder. The only potentially realization you have is that you're on medication for it, right? That's it. And the medication is well tolerated. There's no complication, right? Like you're completely normal. 30 years ago, we had a little bit more of an issues because we didn't have that. And so when we were looking at studies, the things that we were studying was not the same thing that we're studying today. Now we have, our standards are much higher. At the time, the standards were, can we prevent further progression? And that is how the term DMARD came. And so what are DMARDs? So there are Methotrexate, you hear me, and that's usually the one that we start with for rheumatoid arthritis. Sulfasalazine, Leflunomide, Hydroxycholoroquine. Okay, so the really cool thing that they all have like different names, but overall methotrexate, I think we all know it as methotrexate. Sulfasalazine, leflunomide. Sulfasalazine, or that's another drug that works, that almost has the same exact profile than methotrexate. So it can be liver toxic, it can be blood toxic, bone marrow toxic. So basically, it can cause anemia, can cause low white blood cell, and so on. The issue I have personally with sulfasalazine is that it is a sulfa drug. And I find that a lot of patients are actually allergic to sulfa drug. So for example, if you've taken Bactrim in the past and that you have developed a little bit of a rash or a full rash and that you're allergic, you cannot take sulfasalazine. The other thing I don't like about sulfasalazine is that it's many pills. It's like up to 6 pills a day. I don't know for you, but I just feel like per day, that's a lot. Like 7 multiplied by 6, that's a lot, versus methotrexate, where you usually start at 6 tablets once a week, right? So something to consider. But it is efficient. It works. It really does work. And in fact, there were some patients, there were some of my mentors in the past that thought that actually worked better for patients with spondyloarthropathies, such as ankylosing spondylitis or psoriatic arthritis. I will tell you, I've never really seen that difference. For me, if methotrexate works, sulfasalazine may work, but why start with sulfasalazine when I can do methotrexate? Personally, that's how I see it. And then there is Arava, leflunomide. That's the same thing, right? Same thing, sort of the same profile. It's 1 tablet a day, so that's something that's okay, right? Like taking 1 tablet a day is not a big deal. And then it's actually very interesting. In the past, we thought that methotrexate was potentially lung toxic, so toxic to the lungs. And it can be. There is something called hypersensitivity pneumonitis. Oh God. In medicine, we have very, very fancy names to really to not say much. I mean, they say a lot, but let's break it down. Hypersensitivity, you're sensitive too much, right? Hyper, too much, sensitive. And pneumonitis, it just means pneumo, which is the lungs, itis, which means inflammation. So you have inflammations of the lungs because you're allergic, basically. I mean, it's not allergic, but that's what people in general would say, that you're allergic to methotrexate. But the truth is that, yeah, it is a sort of allergic reaction to methotrexate. So that's super, super, super rare. But people thought that because of that, and because, for example, rheumatoid arthritis patients can develop interstitial lung disease, and so fibrosis of the lungs, we thought that it may have been related to methotrexate. And then with time, we have actually found that that's not the case. It's not related. And so we know that it's actually safe for the lungs. Of course, if you have shortness of breath after starting methotrexate, you don't want to continue it. And it is true, if you have a lung disease, you don't want to be on methotrexate. But honestly, I would almost argue that leflunomide or Arava, which is the same thing, doesn't really work. But so to answer the question, right, to go back to that question of like, what's the difference? Like my dog put me on sulfasalazine, or my dog put me on leflunomide, or my dog put me on methotrexate. They kind of all are the same. They work really well. They definitely work really well for patients with rheumatoid arthritis or rheumatologic conditions that affect the peripheral joints. When I say peripheral, shoulders, extremities, but not the back. The back, it doesn't work, okay? But it does work for all of those peripheral joints. And it has the same sort of safety profile of making sure that you're looking at the blood, making sure that you're looking at the liver, and can also cause a little bit of GI distress, all of them, okay? And then we have also Plaquenil or hydroxychloroquine. That I love, because it's not actually immunosuppressive. It's immunomodulating. And so the way I explain it is that it rebalances your immune system, all right? And it does so by changing the pH, so the acidity in some of specific cells. We actually are learning, so it's a very old drug. We didn't actually know how it works and how it worked. And we're learning how it It's kind of a cool way, the way that it's working, but we are still not completely certain of exactly how it works, but it's still pretty cool. And we know that it's not immunosuppressive, which I think is really, really cool. So it's not immunosuppressive. You don't need to do blood work, do an eye exam. If you want to learn more about hydroxychloroquine, I did a YouTube video just on that, so go back there. But the thing that I would say is, yes, it's super safe. You can actually take it if you're pregnant. That's not a problem. The only thing is that it doesn't act as well as methotrexate. So if you have severe rheumatoid arthritis, that is not the one I'm going to give you because it's just not going to work. The thing we may do, though, is to add the methotrexate and the plaquenil together because they are symbiotic relationship, meaning that it's not 1 + 1 = 2, it's 1 + 1 = 3, 4. And in fact, in Europe, very often, arthritis, we start you by putting both of them together. So you very often you start methotrexate plus plaquenil. That's a lot of pills, right? It's 2 pills due to the hydroxychloroquine, so plaquenil once a day, and then methotrexate, we usually start at 6 tablets once a week. Okay, and that's why there's a difference between the different countries. We like biologic in the US because we can actually have access to it because it's a single payer. You're a single payer for insurance. Some countries in Europe want you to be on what we call triple therapy, which would be hydroxychloroquine, methotrexate, sulfasalazine, and that's a lot of pills. But it actually, at 1 year for rheumatoid arthritis, it works just as well as a biologic with TNF inhibitor. So, when you're thinking of the price, it is true that it actually is more value for the price if you do triple therapy. When you think of the amount of drugs that the patient is going to have to take, biologic is so much easier because it's just an injection every 2 weeks, sometimes every week, sometimes every month. I mean, that's like so much easier. But okay, so DMARD are really this class of drugs that were synthetic, not biologic. So that they are this class of drugs that were not anti-inflammatory. So they were not the NSAID, non-steroidal anti-inflammatory, or steroidal treatments such as prednisone. They were not that, and they showed that we were stopping the progression or decreasing the progression of rheumatoid arthritis. And that is why we call them disease-modifying antirheumatic drugs, okay? But that's really just a fancy name to do that. And they kind of all are the same sort of safety profile. And very often, a physician is going to choose the one that he has more, that is more used to, basically, or is going to look at, the different, if you've been allergic to sulfa, we're not going to use sulfa drugs. We're not going to use sulfasalazine. And that is how we started this. Okay. I hope this was helpful. Click on the subscribe button, especially if you're on YouTube, because that really allows us to have more views. I think those Rheumatology 101 are very appreciated by people. So I love doing those. I love answering your questions. So if you have questions, please put them. I'm looking now at Instagram. This is actually a very odd thing, but on Instagram, hi, Nathan, Nicole, Frisco Pedimom, Joe Amigues, and then I, Oksana Bielowska. So hello, I was diagnosed with RA 3 months ago, and the doctor prescribed me just hydroxychloroquine. It took the medicine around 14 weeks to start working. How often do I need to do a blood test? So a very good point. So Oksana Bielowska. So yes, the problem with plaquenil, so hydroxychloroquine, is that it can take up to 4 months to work. So in your case, it looks like it's starting to work, 14 weeks. That's right. You do not need to do blood tests for the hydroxychloroquine because it's not toxic to the liver, to the blood, and so it's not. The only thing you need to do, especially if you see that you're doing really well with it, is to do an eye exam. And the eye exam, we do it in the first year as a baseline. And then personally, I like to do it once a year And that is very, very important. The reason I personally don't necessarily, I like hydroxychloroquine if the RA is very mild, because hydroxychloroquine is such a cool drug that doesn't really have much side effects. And as you saw, there was no need for blood work, right? There's not really need a blood work for the hydroxychloroquine. I do like to do blood work personally just to see that there is less inflammation. And once a year we do blood work just to see where you're at. But it's not for the drug; it's really for the rheumatoid arthritis. So hopefully I helped you. And yeah, I think hopefully this has been helpful. I hope you guys have a great day, a great week, and I will see you next week. Okay, bye everyone.